Okay, so welcome everyone to the Step 1 CVS lecture, the last lecture for today by Dr. Haidari. Thank you so much for joining the lecture. Hope you guys are doing well. If you guys can hear my voice, can I get a yes in the chat box, please? Okay. So while we wait for the other students to come and join, are we ready to sit for the exam for today? Yes or no? Oh, good. And can we do a quick revision of the CVS pharmacology from yesterday, please? Okay, very good. Thank you so much. Now, let's start with the first question. If you have a patient who comes to you with primary essential hypertension and it's an African American patient, which drug of choice are you going to choose for hypertension? Very good. What is the drug of choice for hypertension with heart failure? Very good. Diuretics. What is the drug of choice for hypertension with asthma? Very good. What is the drug of choice for hypertension in pregnancy? Nifedipine, hydralazine, methyldopa, and labetalol. Very good. Okay, next one. Let's move forward. What are the adverse effects of calcium channel blockers? Number one is constipation. Number two is peripheral edema. Can we get an atrioventricular block with calcium channel blockers? Yes. Okay. Next one is, what is the over here? What is the drug of choice for a patient who has acute anginal attack? What is the drug of choice for acute anginal attack? Very good. Now, nitrates. Okay, very good. What is the drug that can cause cyanide toxicity? What is the drug that can cause cyanide toxicity? Okay, good. What is the mechanism of action of sacubitril? What is the mechanism of action of sacubitril? Very good. It's a neprilysin inhibitor. Okay, good. Now, can we talk about some lipid-lowering agents very quickly, please? What is the name of the lipid-lowering agent that will severely decrease or that will severely decrease your triglyceride level? Very good. What are the names of the two drugs that can decrease your LDL level? Statins and PCSK9. Very good. Along with statin and PCSK9, can we also remember the okay, so statin and PCSK9, they're okay. Okay. Next one. What is the name of the drug that can cause hepatotoxicity and myopathy at the same time? Statin. Very good. What is the name of the drug that can cause GI upset and diarrhea? Very good. What is the name of the drug that can cause myopathy and cholesterol gallstones? Very good. What is the name of the drug that can cause CNS dysfunction? Very good. Can anyone explain the mechanism of cardiac digoxin? Yes, Dr. Otero, can you describe the mechanism of cardiac digoxin? Sodium, potassium ATPase. Yes, Dr. Otero, you can speak now. Can you speak now? Yes.
Hello, doctor. Yes.
Yes.
Okay, the digoxin is a medication to treat the cardiac contractility. So the action it will be, we have in the smooth muscle two type of receptor,
Mhm.
calcium, sodium, calcium, ATPase exchanger, and also sodium potassium. So we're gonna treat with digoxin or block the sodium potassium, and then at the same time we're going to have an equilibrium. So if we close or block that potassium, the sodium potassium exchanger, the equilibrium in the cell, it will
Mhm.
be no more sodium inside the cell um, by the sodium calcium exchanger. So it will be calcium inside the cell, and then at the same time we're going to produce more by the sarcomere, um, uh, and then it will be prompt to increase the contractility, the inotropism.
Okay, perfect. Okay, so basically what Dr. Otero has said is that digoxin is a drug that will block the sodium potassium channels. As a result, sodium will not leave the cell. High amount of sodium will also prevent the activity of the sodium calcium exchanger. As a result, when the activity of the sodium calcium exchanger is decreased, calcium remains inside the cell. That increases the inotropy of the cell. Yes, Dr. Otero, is that what it is?
Yes,
Uh,
thank you.
Can you tell me, Dr. Otero, very quickly over here, what is the antidote for digoxin toxicity?
It will be fat fragments.
Fab fragments, very good. If
Yeah.
a patient with digoxin toxicity, Dr. Otero, comes to you with hyperkalemia, is that a good sign or a bad sign?
It's a bad sign.
It's a bad sign, very good. And if I have to talk about one adverse effect that happens with digoxin in the eyes, what is the adverse effect?
It will be like Van Gogh, blue
Van
vision.
Gogh, very good.
Yeah,
Blue, yellow,
yellow vision.
very good. Thank you so much. I really
Thank you.
appreciate it. Okay, absolutely wonderful. So that's the mechanism of digoxin. Is everyone clear about the mechanism of digoxin? Yes or no? Yes. Okay. Now, without further ado, let's not waste any more time. What seems like that you guys have been doing your homework and really have been proud of you guys putting in the work. Now, let's begin our lecture. Today, we are going to have an assessment test. And before we have that assessment test, we are going to finish CVS pharmacology by talking about the last group of drugs. Okay, just give me 1 second. So today we are going to start talking about antiarrhythmic drugs. Antiarrhythmic drugs are extremely important for your step 1, step 2 CK. Now, the reason why antiarrhythmic drugs are very important is because during most of our medical school studies, we have not put a lot of emphasis on these drugs, okay, because they are not to be used by amateur physicians or intern physicians or new physicians, because the amount of adverse effects that's associated with each antiarrhythmic drugs are very wide. So only in the presence of matured physician or a supervisor are we supposed to use antiarrhythmics. So that's why we were taught more about other drugs that are more important, but not antiarrhythmics. Okay, so that being said, antiarrhythmics, we are going to be using a lot of different types of mnemonics, a lot of different types of stories and everything to remember all the high yield information. Okay, is everyone ready? Yes or no? Can we begin? Okay, let's begin. Now, antiarrhythmic drugs are basically divided into four classes. Okay, there are four classes of antiarrhythmic drugs. When we talk about the first class, let's talk about class one. Let's talk about class one. Class one antiarrhythmic drugs. What they do is they have primarily one single function and one single function only. That is, they block the sodium channels. Very easy to understand, very easy to remember. That is, the class one will block the sodium channels. Now, what happens when you block the sodium channels? We know that we have the myocardial action potential that stays at a negative 85 millivolt of resting potential. And then with the opening of the sodium channels, we have an active depolarization. And with this active depolarization, from here to here, right, we have the opening of the sodium channels. And then from here, the sodium channel closes, the potassium channel opens, it falls, and then it reaches a plateau because of potassium and calcium exchange. And then calcium channel closes and potassium channel opens further, and then we have the fall of the action potential. And this is called repolarization. So if I were to block the sodium channel over here, instead of this line being straight and like this, could it have been like this? Yes or no? The answer is yes. So if you stop or if you slow down the opening of the sodium channel, will it take a more slanted approach for the action potential? The answer is yes. So how would the graph look? It would look something like this. Are we clear? Yes or no? Everyone? Can you guys hear my voice? Are we clear about this? Yes? Okay. Right? So that's that. So can we say that the action of class one antiarrhythmic drugs is that they decrease the slope of phase zero, Yes or no? They decrease the slope of phase zero. Okay. So this is merely the function of all the class one antiarrhythmic. Now, depending on which and how they work, we have three classes: class 1A, class 1B, and class 1C. From over here, class 1C is a very strong sodium channel blocker. Class 1B is a very weak sodium channel blocker, and class 1A is a moderate intensity sodium channel blocker. So depending on how much they block, we have the action potentials. For example, for class 1C, the graph would look something like this. For class 1B, the graph would look something like this. Moderate. And for weak. And for moderate, we will have something that looks like this. One second. Okay, are we clear? Yes or no? Is this graph over here, the blue graph, is it showing that there's a lot of sodium channel blockade? Yes or no? The answer is yes. If you compare this one with this one, okay, this is a weak sodium channel blocker. So since it's a weak sodium channel blocker, can we say that it's very close to the actual graph? Yes or no? Just a little bit over here. And this one is a moderate sodium channel blocker, right? This one is a moderate sodium channel blocker. So this is a weak. This is the strong sodium channel blocker. My apologies. This is the weak, and this is the moderate sodium channel blocker. So depending on these functions, we have the three names of the drugs. Are we clear about the first introduction of the class 1 antiarrhythmics? Yes or no? Very quickly, class 1A, B, C. Which one is the weaker? Which one is the stronger sodium channel blocker? Stronger sodium channel blocker is? Very good. The weakest sodium channel blocker is? Oh, good. Now, how many of us have how many of us over here are in the US? Are you guys in the US or excuse me? Is there anyone who's not in the US? Yeah. So did you guys come here recently, or have you guys been in the US for a long period of time? Have you guys been to the US recently, or okay, so you guys have been here for a long period of time? 30 plus years. Okay, good. Okay, now good. The reason why I'm asking you this is I personally, can I share one of my favorite experience of being in the US? Yes, okay. So one of my favorite experience of being in the US is going through drive-throughs. You guys know what drive-throughs are? I'm pretty sure since you guys have been staying here for so long. You guys know what drive-throughs are, right? Drive-throughs are basically car wash or fast food drive-throughs. Okay, so fast food drive-throughs. Okay, this is one of my favorite experience. That is, I just love the way how people in the US, they have modernized the availability of fast food with minimal human interaction. You simply walk or you drive through their McDonald's or whichever fast food store they have. You order the food that you want, and with very minimal human interactions, they will serve you the food. You can either bring it home or you can eat it in your car. That's a drive-through. Yes or no? You live in KS and you have drive-through. Very good. Okay. So you guys are all aware what drive-throughs are. So can I share what I usually order in a drive-through? So what I usually order in a drive-through is, okay, so I'm a big guy, right? I need a lot of food. So the first thing that I order, number one, is I order a double quarter pounder burger. Okay, so a double stack of patties of quarter pound of meat in my burger. Next, can I share what I order next? Yes, please. What I order next is I realize that most of the time when I order burgers through a drive-through, and my burgers, they usually lack lettuce and mayonnaise. So lettuce and mayonnaise are very important for me, right? So I usually ask for more lettuce and for more mayonnaise. Okay. And last but not the least, can I really have a burger if I don't have access to fries? Yes or no? The answer is no, right? Because burger and fries, it goes hand in hand. So I usually ask for fries, please. Fries. Okay. So what do I order? Can anyone tell me what I usually order, what I usually like to order? Number one, when I go through a drive-through. Number one, what do I usually order when I go through a drive-through? Fast answers, please. Quarter pounder, double quarter pounder, very good. Number two, what else do I usually like in the burger? I usually ask more for it. Lettuce and mayo, very good. And then at the end, what else do I ask? Fries, please. Okay. So number one, double quarter pounder is your name of the drugs for class 1A. For D, we have disopyramide. For Q, we have quinidine or quinidine, however you want to pronounce it. And for P, we have procainamide. Are we clear? Disopyramide, quinidine, and procainamide. These are your class 1A. Next one. Are we clear? Yes or no? Guys? Okay. Next one. For class 1B, we have lettuce and mayonnaise. For lettuce and mayonnaise, we have lidocaine and mexilatine. Mexilatine. Are we clear? Next, class 1C. Fries, please. For fries, please, we have flecainide and propafenone. Are we clear? Yes or no? Are we clear or not? Okay. So can we use this mnemonic to remember the names of the drugs, please? Can anyone right away, let me test your memory. Let me see how sharp your memory is. If you make mistakes, that's even better. Can anyone participate actively by naming me the class 1 drugs? Anyone? Yes, Dr. Allen, thank you so much. You can unmute yourself.
Okay, so class 1A is a moderate, and then mnemonic is double quarter pounder. D for disopyramide is quinidine. Powder is procainamide. 1A.
1B.
Okay. 1B is a weaker sodium blocker, and the mnemonics lettuce and mayo. L for lidocaine and M for mexilatine.
Very good. Class 1C.
Class 1C is the strongest sodium blocker, and that's fries, please. So F for flecainide,
Okay.
and P for propafenone.
Propafenone. Very good. Thank you so much. Okay, absolutely wonderful. So that's that. The rest of you guys, are you guys, I mean, did you guys understand the way we can use the mnemonic to remember the names of the drugs? Yes? Okay, very good. Now let's move forward very quickly. Okay, now let's move forward over here. I am going to talk about a very important thing over here. First and foremost, let me ask you very quickly, if you have a patient who has arrhythmia, right? Who has arrhythmia after they have had a history of myocardial infarction, right? After they have had a history of myocardial infarction, now all of a sudden they have arrhythmia. Are you going to use a strong sodium channel blocker, or are you going to use a weak sodium channel blocker? The answer is, can anyone tell me what the answer is? Very good. We are going to use a weaker sodium channel blocker. Why? Because if we use a stronger sodium channel blocker, there is a possibility that the arrhythmia could be worsened. Because when you block the sodium channels in a patient who has already had myocardial ischemia, this can result in abnormal and asynchronous release of excessive impulses from the ASI node, further prolonging the arrhythmia. So we don't want to give any drugs that is very strongly adherent, right? And so what we would do is that we would, out of 1A, B, C, we would always choose class 1B. That is lettuce and mayonnaise, right? Lidocaine and mexilatine. These are the choice of drugs for a patient who has had a history of MI. Okay, these are the drug of choice for a patient who has had history of MI. So that's that. Next one is the next thing that we are going to talk about is some very quick adverse effects. Okay, some quick adverse effects of the drugs. Number one is over here, the class 1A drugs, right? They are very high yield for causing syndrome known as kinchonism. Okay? And the only drug that can cause kinchonism is quinidine. Okay, so quinidine causes kinchonism. Do you know what kinchonism is? Kinchonism is a state where patients usually experience a lot of headache and tinnitus. So they experience a lot of headache and a lot of tinnitus. This was basically kinchonism. This syndrome usually comes from the history of people trying to have drugs that have that were taken from a plant, right? I forgot the name of the plant. It could be I actually don't remember. My apologies. I honestly do not remember the name of the plant, but there was a plant which resulted, if you had this, then people would experience headache and toxicity. I mean tinnitus, headache and tinnitus. So kinchonism is very highly associated with quinidine because this drug is synthesized from that plant. So that's it. Next one is that we have another drug that causes drug-induced lupus, and that's very high yield. That is drug-induced lupus. This is procainamide. Now, we'll talk about lupus in the future, but what is drug-induced lupus? Drug-induced lupus is basically when you have certain drugs such as isoniazid, hydralazine, procainamide. These drugs, they initiate the formation of antibodies against your DNA complexes, and patients have an exacerbation of SLE, or they have new onset of SLE-like symptoms. Are we clear? Yes or no? Next one that's very high yield is that all three of these drugs, double quarter pounder, deep double quarter pounder. All three of them are known to cause Torsades de Pointes, very high yield, or they have the tendency of increasing your QT interval. Are we clear? Yes or no? Okay. So can we remember these handful of adverse effects for the class 1A drugs, please? Yes? Okay, good. Next one is class 1B drugs. What are their adverse effects? Class 1B, they usually do not have a lot of adverse effects because they're very weak, right? They're very weak sodium channel blocker. So it's not very high yield. So over here, if you want to remember something, just remember that they have a tendency of causing CVS and CNS depression. Okay, that's not high yield. So it will not be tested in the exam. So you have nothing to be worried about. Class 1A, however, is very high yield for the exam. Next is class 1C. Class 1C, the only adverse effect that's high yield for class 1C is, since this is a strong sodium channel blocker, they can cause arrhythmia. So we call this pro-arrhythmic. Are we clear? Yes or no? They are a pro-arrhythmic drug. Okay, isn't that simple? Yes or no? You do not have to remember a lot of different types of activities? Yes? Okay, so over here, first and foremost, for class 1 drugs, if I have to ask you very quickly, so we're done with the adverse effects, we're done with the mechanism of action. Now let's talk about their clinical use and then let's move forward. Now, very quickly, for class 1 drugs as a whole, class 1, can you tell me whether they have a good activity in atrial arrhythmia or ventricular arrhythmia? Fast answers, please. Are they supraventricular or ventricular? The answer is class 1s are used for Anyone? Very good. Atrial arrhythmias. So can we use them for atrial fibrillation, supraventricular tachycardia? Yes. Yes or no? Yes, the answer is yes. Okay. So that's that. So most of the time we use this for atrial arrhythmias, right? So next one is, out of the three drugs, which one will have a better use after a patient has had a history of myocardial infarction? The answer is class 1B. Very good. Okay, class 1B drug. Next, another thing that I want to talk about for class 1 and class B is that over here, class 1A is the only drug, right? Class 1A is the only drug. Let me just write this down over here. Class 1A is the only drug that can increase your action potential duration, right? And it can also increase your QT interval, but we already talked about that. But this is important because class 1A is a moderate sodium channel blocker, right? And class 1C is a strong sodium channel blocker. So if you basically talk about class 1A and class 1B, there is a way how class 1A increases your action potential duration. But when you compare the action potential duration with class 1 and class 1A and 1C, then the action potential duration increases only with class 1A, not with class 1C. Okay. And now, if you ask me why, the answer is because out of A, B, and C, C is a strong blocker, B is a weak blocker, A is a moderate blocker. Now, if we block the sodium channel very strongly, and if the curve gets really steep like this, the action potential duration initially will be prolonged like this, but at the next duration, what will happen is there will be a sudden severe rise of action potential. Have I made myself clear? Yes or no? Because what happens is whenever the electrical circuit of the heart, whenever it undergoes some sort of a depression, do you remember I told you that whenever the electrical circuit of the heart, whenever it undergoes some sort of a problem or depression, it starts freaking out and it releases a lot of impulses? Yes or no? Isn't that the same thing that we see in myocardial infarction or any other heart problem? Whenever there is a effect of the electrical circuit of the heart, it starts to freak out and it releases a lot of impulses. So since after blocking the sodium channel, we have, we have the electrical circuit of the heart, it realizes that there's something that's obstructing the flow of sodium inside the myocardial muscle. So what it does is it increases the electrical action potential, and there's a strong depolarization right after this activity. So the action potential over here does not increase. Eventually, it either remains the same or there is minimal effect on action potential. If there's a weak sodium channel blocker that only increases the slope like this a little bit, then this is not really effective for the action potential duration. This does not affect the action potential, number one. Number two is that this does not really increase the intensity of the electrical outflow from the SA node, right? So over here, instead of the increase of action potential, class 1B drugs can actually decrease your action potential. They can actually decrease your action potential duration. Okay, so they can increase your action potential duration, and basically meaning that over here, the class 1B drugs, since they decrease the action potential duration, they basically will they basically will not allow a strong, a very strong contraction of the myocardial, of the cardiac myocytes. So that's that. And then we have the moderate. So when you block the action potential you block the entry of the sodium and you keep it in between weak and strong, right? That's when you have the true increase of the action potential duration, right? And why do you have the increase of action potential duration? You have the increase of action potential duration of class 1A That's because over here, when you moderately block, this does not really affect the electrical impulses as much, so they do not become very arrhythmic. And at the same time, you're also giving the heart enough time to sort of block the sodium channels and get accustomed. So that's that. So now the thing is, how do we remember this information very quickly? If you strongly block the sodium channel, will the heart freak out? Yes or no? That's one mnemonic. Fast answers, please. If you strongly block the sodium channel, will the heart freak out or not? Yes or no? The answer is yes. As a result, will there be excessive impulses that's released from the SA node? The answer is yes. As a result, can there be chances of arrhythmia? The answer is yes. But will there be any effect on the action potential duration? Yes or no? The answer is no. Okay. Now, next one is, if you block the sodium channels weakly, can it increase the action potential duration, or will it decrease the action potential duration? Fast answers, please. It will decrease the action potential duration. Okay. Next one is, if you moderately block the sodium channel, will it increase the action potential duration or decrease the duration? Very good. Increase. Okay. So that's that. Now, with that being said, we are done with class 1A antiarrhythmics. Are we clear? Yes or no? No. So before I move on to class 2 or class 2 antiarrhythmics, can I give you guys 2 minutes to go through this page? Yes or no? Let me just underline this. Antiarrhythmic drugs. First and foremost, class 1A, class 1B, class 1C. These graphs are very important. Based on these graphs, you will have questions. Okay. For example, if they show you this graph, can you assume that they are talking about class 1C? Yes or no? Fast answers, please. Okay. If they show you this graph, can you assume they're talking about class 1B because of the weak activity? Yes. And this one represents class 1A. Okay. Then over here, the names of the drugs are very important. The adverse effects of the drugs are very important, especially kinchonism. And where is SLE? Okay, SLE-like syndrome for procainamide and prochalcedopine. For class 1B, the best thing is they are used for post-MI. They're weak sodium channel blockers. Class 1C, they are pro-arrhythmic. So it's contraindicated in ischemic heart disease. That's that. All of them are used more or less for supraventricular tachycardia. And the AP duration is very important. For class 1A, it's increased. For class 1C, the AP duration is minimal or there's no effect. And for class 1B, the AP duration is decreased. Okay, so these are the handful of information that you only need to remember. Is that easier? Yes or no? Fast answer, please. Yes or no? Yes, okay, good. So can I give you guys 2 minutes before I can move forward to class 2 and class 3 to read this page? Can I get some feedbacks, please? Can I give you guys 2 minutes to read this page? Yes, okay, thank you so much. I'm going to give you 2 minutes exactly. Read this page. I'm going to give you some time, and then after that, I'm going to ask you questions, and then I'll move forward. Thank you so much. Okay, so 2 minutes are up. Can we move on, please? Yeah. Good. Does anyone have any questions? Yes or no? Does anyone have any questions from class 1 drugs? Okay, no questions. If you guys have no questions, then let's move forward to class 2 drugs. Okay. Class 2 drugs are very easy to understand. Class 2 drugs are what type of blockers are class 2 drugs? Class 2 drugs. They are your, very good, beta blockers. Okay, they are your beta blockers. Beta blockers especially are very, very important because do you guys realize that if you block the beta receptors, then there is decreased sympathetic activity, right? And we know that sympathetic activity is known to increase your heart rate and increase your contractions. But let's focus on heart rate. Sympathetic activity increases your heart rate. Are we aware that sympathetic activity increases the heart rate by increasing the electrical conduction through the SA node, AV node, and the bundle of His? Yes or no? The answer is yes. So if you block the beta receptor, the heart rate will decrease. And the best thing is the SA and AV nodal activities and electrical transmission of impulses, they will also decrease. Are we clear? Yes or no? Okay. Now the next one is, if I have to ask you which one is more sensitive to a beta blocker, an SA node or an AV node? The answer is the AV node is more sensitive to a beta blocker. Do you know why AV node is more sensitive to a beta blocker? The answer is because AV node already is in sync with the mechanism of beta blocker. What does that mean? That means that AV node already is responsible for decreasing your rate. That's why, do we not call AV node the rate slowing node? Yes or no? We call AV node the rate slowing node. So if there is a drug that is also favoring the same mechanism, is there a possibility that they will work together? Yes or no? The answer is yes. So AV node, and so beta blockers, they basically work in the AV nodes, right? Now, the next thing is for AV nodal, for blocking the electrical impulses through the AV nodes, can anyone tell me what happens to the PR interval in beta blocker? Is it increased or is it decreased with the use of beta blocker? Very good. There's increase of PR interval. The interval is increased, right? So normally it should look something like this, but over here, this is B, this is R, this is R, right? But when you block the beta receptors, the heart rate basically decreases. So there's a time between the initiation of the ventricular contraction, since the AV node is being blocked by the beta blockers. So it looks a bit like this. So as a result, this PR interval from here to here, isn't this one more increased? Yes or no? The answer is yes. Have I made myself clear? Yes or no? Okay. Now, if I have to talk about the adverse effects of beta blockers, I'm pretty sure you guys all know the adverse effects of beta blockers. Number one, the easiest way to talk about this is to talk about your sympathetic activities. Now, are we aware that every mammalian species, right? Human beings, we're mammals or not? Yes or no? Fast answer, please. Are we mammals? Do we produce babies and give birth to babies, or do we lay eggs? Fast answers, please. We lay eggs, or do we give birth to babies? Fast answers. We give birth to babies, right? Yes or no? Good. So every mammalian species, we're born with two types of innate activity. One is fight, another one is rest. Fight or flight or rest. Okay, so now let me tell you something. Over here, if you have a very ferocious dog, right, who's chasing you. Okay, this is a very rabid dog, and that dog is chasing you right now. Can you tell me what are some of the changes that will happen? First and foremost, what is the first thing that's going to happen? The first thing that's going to happen is you are going to see the dog. Yes. And you see and you notice the activity of the dog. What that is going to do is after you see, the electrical impulses are going to travel all the way through your optic nerve, optic tract, optic chiasma to the occipital lobe. From the occipital lobe, it will go all the way to where? Through the fasciculi and the white matter, it will go through your hypothalamus. In the hypothalamus, you have your autonomic nervous system, right? The anterior and the posterior systems. They will stimulate the sympathetic center in your hypothalamus. Once it stimulates the sympathetic center in your hypothalamus, electrical impulses are going to shoot directly down at your thoracolumbar outflow, right? And from there, it will travel from the thoracolumbar spinal region to the preganglionic fibers. From the preganglionic fibers, the impulses are going to transmit through the postganglionic fibers, and we are going to have a constellation of signs and symptoms. Number one, what will happen to our heart rate? Will it be high or will it be low? Heart rate is going to be high. Because why is heart rate going to be high? Because we are in a state of fear. We are in a state of fear, and our brain needs to work more. So the heart has to increase its blood supply so that the brain can work properly. Next, what will happen to the glucose level? The glucose level will be high. Gluconeogenesis will take place. So if gluconeogenesis takes place, that's because the brain can get enough glucose supply, right? Then next one is we are going to have increased rate and depth of breathing, right? Because our breathing will increase so that we can get enough oxygen in our body so that once again, our brain can work properly. Next is, should we have vasodilatation or vasoconstriction in sympathetic activity? The answer is we should have vasoconstriction in sympathetic activity. Does anyone know why we have vasoconstriction in sympathetic activity innate? The reason is the way that we were created is if we run from the dog, right? Let's say we are running from the dog, and if there's a sharp object, right? If there's a sharp object, if your vessels are constricted and you get hit by the sharp object, will you have more loss of blood or less loss of blood? Fast answers, please. The answer is, if it's vasoconstricted, you will have less loss of blood. The vessels are already constricted, right? So if there's something that struck, there will be less loss of blood. If there's less loss of blood, can you survive longer? Yes or no? The answer is yes. As simple as that. So S for sympathetic, S for survival, as simple as that. Then next, when we're running away from the dog, do we worry about urination or defecation? Yes or no? The answer is no, because there is decreased activity of the bladder and the bowel, as simple as that. Okay, do we have excessive salivation? No, the answer is you have dry mouth. So these are some of the things. So I just discussed some of the sympathetic activities off topic. The reason why is because we need to talk about the side effects of beta blockers. Now, did we understand all the sympathetic activities in the body? Yes or no? Fast answers, please. The answer is yes. Oh, another thing over here, very quickly. In sympathetic activity, do we have bronchodilation or bronchospasm? The answer is we have bronchodilation, right? Why? Because we want to make sure that there is enough oxygen that's coming in so that our blood is oxygenated so that our brains can work in a sympathetic activity. Next one is, can we have, when we are running away from a dog, is it possible for mammals to be involved in sexual activities? Yes or no? The answer is no, right? Okay, so that's that. So during sympathetic activity, right, there could be sexual impotence and decreased libido. So these are some of the things over here. Now, over here, let's talk about the adverse effects of beta blockers. What are the adverse effects of beta blockers? First and foremost, in the lungs, can we have bronchospasm? Because we know sympathetic activity causes dilatation. So beta blockers will block the sympathetic activity. We will have bronchospasm. Next, Sympathetic activity increases your heart rate. Beta blocker will decrease your heart rate. Are we clear? Yes or no? Sympathetic activity keeps you alert. Beta blockers will decrease your alert. As simple as that, alertness. Okay, sympathetic activity increases your glucose level. Beta blockers can decrease your glucose levels. Okay, beta blockers can decrease your glucose level. And at the same time, if someone has hypoglycemia and is taking beta blockers at the same time, can the sign symptoms of hypoglycemia show with beta blockers? Yes or no? The answer is no. Okay, so they can mask the sign symptoms of hypoglycemia. Next one is beta blockers can also cause, can I say that beta blockers can also cause a little bit of impotence? Yes or no? The reason being is because sympathetic activity initially will cause decreased impotence, but when sympathetic activity decreases, there's a balance between sympathetic and parasympathetic that allows for sexual activity, that allows a proper sexual activity. But when we give beta blockers, what's happening is that we're completely blocking the sympathetic system. So patients, they have difficulty in penile erection or clitoral erection or enlargement. So so impotence is very important. Beta blocker, bronchospasm is very important. Decreased heart rate, decreased alertness, masking the signs of hypoglycemia. These are all very important. These are some of the high yield adverse effects for beta blockers. Are we clear? Yes or no? Next one is there a possibility that we can get beta blocker toxicity? Yes or no? The answer is yes. If we have a beta blocker toxicity, what are some of the drugs that we can use to treat beta blocker toxicity? The drugs that we will use to treat beta blocker toxicity is called SAG, S-A-G, SAG. S for saline, okay, S-A-L-I-N-E, IV fluid, A for atropine, G for glucagon. Because beta blocker decrease your glucose level, we will give glucagon. Are we clear, guys? Yes or no? Yes? Okay. Good. Can we talk about class 3 antiarrhythmic drugs? No. What are the class 3 antiarrhythmic drugs? Now, how do we remember this? For class 3 antiarrhythmics, there is a mnemonic. The mnemonic is AIDS, AIDS. Okay, so with AIDS, what do we have? A for amiodarone, I for ibutylide, D for dofetilide, S for sotalol. Are we clear? Yes or no? Now, class 3 antiarrhythmic drugs, these drugs, they have a tendency of blocking your, which channel? Can anyone tell me which channel? Potassium channels. Okay. They have a tendency of blocking your potassium channels. So class 1 was responsible for blocking the sodium channels. Class 2 was responsible for blocking the beta receptors. Class 3 is responsible for blocking the potassium channels. Okay, so this is very simple. There's not really much to understand over here. If you block the potassium channels, is there a possibility that there could be a sustained, for example, this is the normal, and after you give a potassium channel blocker, can it look something like this? Can it look something like this? Sodium channel will remain normal, but yes? Yes or no? Yes. Okay, so that's that. So can we say that potassium channel blockers also increase your action potential duration? Yes or no? The answer is yes. How? By increasing the state of repolarization. So they increase your action potential duration. Another thing over here very quickly is that can potassium channel blockers increase your QT interval? The answer is yes. We talked about this before. That potassium channel blockers, they increase your QT interval. Out of the 4 drugs, which one has the most QT interval increasing activity? The answer is sotalol. Out of the 4 drugs, which has the least QT interval increasing activity? The answer is amiodarone. Are we clear? Yes? Okay. Now, one of the highest yield class 3 antiarrhythmic drug is amiodarone, right? That one of the most highest yield class 3 antiarrhythmic drug is amiodarone, and amiodarone adverse effect is extremely important for your step 1 examination. Okay, so basically amiodarone is used for the treatment of ventricular tachycardia. It's used for the treatment of ventricular tachycardia. For example, if someone has ventricular tachycardia, do you remember how I said we use 2 types of cardioversion? We have pharmacological cardioversion, and then we have electric cardioversion. For pharmacological cardioversion of ventricular tachycardia, we use amiodarone. Have I made myself clear? Yes or no? The answer is yes. Okay. So how important is amiodarone for ER physicians or emergency doctors? It's very important, because a lot of different types of patients are going to come with VTAC, and we have to choose this drug accordingly. So we should know how this drug works. I want you guys to realize this. Amiodarone has this word, IOD. Okay, IOD. IOD stands, IOD could mean iodine, yes or no? So amiodarone has the ability of causing severe thyroid dysfunction. This can either cause hypo or hyper. We're not entirely sure. Hypo or hyper. Are we clear? Next one is amiodarone can cause severe hepatotoxicity, because amiodarones are broken down by the liver and the metabolites are toxic to the liver. Number 2, amiodarone can cause severe pulmonary fibrosis, because how? The way that they cause pulmonary fibrosis is that a portion of the drug can act as a haptane. Haptane are drugs or portions of drugs that has the ability to act as antigens. And whenever we have haptanes in the drugs and we have antigens from the drugs, there's formation of antibody, and antigen-antibody reactions can result in the activity of complement system, and this can result in inflammation and fibrosis. Are we clear? Yes or no? Yes. Next one is that the antiarrhythmic drugs, right? These drugs, they also have, amiodarone, this haptane, they also have the ability of getting deposited in the patient's eyes, right? And in the patient eyes, they get deposited, and whenever they do that, we have a sort of, I would say, blue, like a blue tinge, right? Sort of a blue tinge in the eyes, very similar to digoxin, but it doesn't cause blue discoloration of the vision. And another place where they can get deposited is the skin. In the skin, they can also have blue-gray deposits. Okay, so what's the difference between this and digoxin? In digoxin, there is blue-yellow vision. Over here, vision is okay, but there is blue pigment deposition in the skin and to some extent in the eyes, but more in the skin, okay, than in the eyes. Have I made myself clear? Yes or no? So now, why is this important? Why is this adverse effect important? A patient who has amiodarone, are you going to routinely check their pulmonary function test? Yes or no? Yes. Are you going to routinely check their liver function test? Yes. How about their thyroid function test? Yes. Okay. Good. Next question is, out of all the class 3 antiarrhythmic drugs, which one can cause torsades de pointe and QT prolongation? One more time. Yes, class 3. Which one? Out of all the 4 antiarrhythmic drugs, which one? Sort of. Okay, next. Can we talk about the last class 4 antiarrhythmic drug very quickly? Class 4 antiarrhythmic drug. Are you guys ready? So let's talk about the class 4 antiarrhythmic drug. The class 4 antiarrhythmic drug is a calcium channel blocker. Are we clear? They are a calcium channel blocker. Okay, so calcium channel blocker, we know that in the pacemaker action potential, we have phase 0, right? Then phase, we have the funny sodium current phase, then we have the calcium phase, then we have the potassium phase. Yes or no? Over here, if we block the calcium channel, can there be a slow depolarization? Yes or no? Can this look something like this? The answer is yes or no. Yes or no? Yes, no, okay, good. So can we say when we block calcium channel, we could also get increase of PR interval? Why? Because in the myocardial action potential, isn't this the phase of calcium channel activity? Yes or no? Right? Isn't this the phase of the calcium channel activity? The answer is yes. So if you block the calcium channel, what would happen? Isn't there a possibility that there could be excessive repolarization due to exit of potassium? And there could be excessive repolarization in the myocardium? The answer is yes. So if there's a lot of repolarization next time, when you want to initiate an action potential, will there be an increased time that's taken to initiate the action potential? The answer is yes. So this increased time that's taken to initiate another action potential after you block the calcium channel, this can increase your AP duration. Are we clear? Yes or no? Everyone? Okay. What are the adverse effects of calcium channel blockers? We just studied them. The same adverse effect they can cause what? Constipation, flushing, edema, and atrioventricular block. Okay. Are we clear? Yes or no? Okay. Now, next one. Next one is two other antiarrhythmic drugs. Some other antiarrhythmic drugs. Number one, we have a miscellaneous drug. We have a miscellaneous antiarrhythmic drug. This antiarrhythmic drug is called adenosine. Adenosine, the way that it works is that it increases the CAMP activity inside the cell, and that increases the potassium out of the cell. It increases the rate of potassium outflow of the cell. Just give me 1 second. So the way that adenosine they work is that they increase the potassium out of the cell, right? And then what happens? You have basically this adenosine. Where are they used for? That's what I wanted to talk about. Adenosine, they are used for certain supraventricular tachycardia. For example, when we see an EKG, right? If it looks something like this, right? And there's no P wave and there's increased activity over here, can we know for sure if it's atrial fibrillation or atrial flutter? The answer is we cannot know for sure if it's atrial fibrillation or atrial flutter. So to diagnose what type of supraventricular tachycardia this patient is going through, we can give the patient adenosine. Adenosine will then help us identify what sort of a problem this is. If it's atrial fibrillation, then there will be absence of P waves and there will be irregular waves like this, right? And then if it's atrial flutter, then it will have something like this. So, and after we give adenosine for supraventricular tachycardia, we can try to identify what sort of a problem this patient is going through. Are we clear about adenosine, guys? Yes or no? Okay. Now, next one is adenosine. Is it a type of drug that can cause vasodilatation by increased CAMP activity? The answer is yes. So can they cause flushing, hypotension, coronary steal syndrome? Yes or no? The answer is yes. Next one is in torsades de pointe, we use another type of a drug that decreases the arrhythmia. Is the name of the drug is magnesium sulfate. Okay, this is another group of drugs. Are we clear? Yes or no? Okay. Last drug. The last drug that we will talk about for CVS and end our CVS is ivabradine. Ivabradine. What is ivabradine? Ivabradine is basically a drug that basically what it does is it inhibits the funny sodium channel. Do you guys remember the funny sodium channel and pacemaker action potential? Right? They increase the activity, they decrease the activity of the funny sodium channels and pacemaker action potential. As a result, do we have prolongation of the electrical transmission from SA node to AV node? Yes or no? If you block the funny sodium channels, the answer is yes. Okay. So can we give them in patients who have chronic angina? Okay. In chronic angina, isn't there a possibility that patients can suffer from arrhythmia all of a sudden? Yes or no? And have sudden cardiac arrest? The answer is yes. And what about in chronic angina? Let's say that a patient who has the possibility of having arrhythmia, but cannot tolerate beta blockers. For example, let's say the patient has asthma, or let's say the patient has any other disease for which he cannot take beta blocker. Let's say he has diabetes. So in those patients, we give ivabradine. Are we clear? Yes or no? Okay. Okay. One more question they ask about ivabradine is that what was the name of the cardiac drug that caused discoloration? The answer is digoxin. Do you remember blue-yellow discoloration? Yes, Van Gogh's discoloration. There's another drug that can cause discoloration or visual problems. That is ivabradine. They cause severe visual brightness. Are we clear? Yes or no? Yes? No. Good. So with that being said, we are done with the CVS pharmacology. Okay, so congratulations. And thank you so much for putting your attention in the entire lecture. Did you guys understand CVS? Yes or no? Yes? Okay. Now, we usually take 10 days to finish CVS, but for this batch, we have finished CVS in 9 lectures, which I'm really proud of, which I would not have done if it wasn't for you guys. So thank you so much for putting your attention in the class, and thank you so much for your overall performance. Now, with that being said, can we take a 5-minute break and begin our exam assessment? Yes. Okay. Okay, so we have 10 students: Dr. Dalia, Dr. Nazara, Dr. Ithar, Dr. Ellen, Dr. Otero, Dr. Noon Mohammed, Dr. S, Dr. Sarah, and Dr. Tasneem. Are we all going to sit for the exam? Yes or no? No. Yes, good, very good. The rest of the students who could not come to the class for whatever reason, and to all the students who are listening to the recording, I would also appreciate if you guys can take the time to take the exam while we are taking the exam, and then match the answers and let us know your results. Okay, so thank you so much. So let's take a 5-minute break. At 11:05, let's begin the exam. Have I made myself clear? Yes or no? Okay, before I do this, what is the next topic or next system that you guys want to begin from next week, Monday? Because tomorrow is a holiday for Christmas Eve, and then our next class will be on Monday. Which system do you guys want to begin with? renal or pulmonary or pulmonary. Okay. Um, okay. Let's start with the renal system. Okay. Are we clear? Yes or no? We will start with the renal system. Reproductive, I want to start later because if you do not read the renal system first, then you cannot understand the reproductive system. Right? So from Monday, we will start talking about the renal system. Okay, so thank you so much. Let's take a break for 5 minutes and then let's come back. Bye-bye. Okay, is everyone ready? Yes or no? Okay, can you guys see my screen? Can you guys see my screen properly? Okay, is everyone ready with a paper and a pen where they can write their answers? Yes. So we are going to conduct an assessment exam on 40 questions from cardiovascular and the endocrine system. The difficulty level is set at moderate. And you guys will get 1 hour to complete the exam, 1 minute and 30 seconds for each question. If you guys have any questions or you cannot understand or you need me to scroll up or scroll down, please either unmute yourself or contact me in the chat box. Okay, right back in the chat box. So with that being said, best of luck and let's begin. Okay, can I get everyone's attention, please, in the chat box? Can I get a yes, please? Okay. Are you guys understanding the questions and the pattern of the questions? Yes. Okay. We're done with 20 questions. That's 50% of the exam. Do you guys want to take a short break and then begin the next 20 questions? Or do you guys want to continue right now, whichever you choose? Continue? Okay, so let's begin. Okay, so we're not taking a break. We're continuing. Let's finish the next 20 questions. Best of luck. Okay, can you guys hear my voice? Yes or no? Yes, okay, good. So we're done with the exam. Congratulations. Let's take a break for 10 to 15 minutes and then let's come back and I'll tell you the answers. We'll discuss the questions and then we'll see how you guys did. How do you guys feel about the exam? Do you feel that you might have done well? Were the questions easy? Were the questions easy? Yes or no? Fair questions. Okay, good. So hopefully you guys will do well. Let's take a break for 15 minutes and then let's come back. Okay, thank you so much. Okay, is everyone back from their break? Yes or no? Okay, just give me 1 second. All right, so let's begin. Is everyone ready for the first question? Okay, Dr. Itar is ready. Who else is ready for the first question? Are we ready to begin? Yes? Oh. So let's begin with the first question. Which of the following adverse effects most commonly associated with the long-term use of this medication? Which one did you guys choose? Very good. Okay, so did we not just talk about this? Yes or no? Yes, congratulations. Good job. Let's move forward. Which one of this would most likely trigger the ventricular contraction? Which one did you choose? Okay, so the answer for this one is C. Okay, why? Because over here, the patient came for chest pain. He has a history of hyperlipidemia. ECG shows P waves independent of QRS. This is a third degree AV block, yes or no? Is this the third degree AV block? The answer is yes. Okay. Which of the following is the most likely trigger? The most likely trigger for this one is not ectopic atrial foci, because this is for atrial fibrillation. This is due to bundle of His. When the SA node cannot transmit the impulses, the bundle of His, they have their own impulses. Have I made myself clear? Yes or no? Let's move forward. Which one did you guys choose over here? Which of the following sets of laboratory values would be expected on further evaluation? The answer for this one is A. Okay, because this is a patient of hyperosmolar hyperglycemic test. Okay, is this diabetic ketoacidosis? Yes or no? The answer is no. Why? Because beta hydroxybutyrate is negative, which shows that ketone bodies are not being produced. Are we clear? Yes or no? Okay, let's move forward. The correct answer for this one is number B, right? I think this is pretty self-explanatory. Does it need any further explanation? This one? No. Okay, let's move forward. Does this need any explanation? Oh. Next one. A biopsy of the mass is most likely to show what? What do you think this this mass is? This is an atrial myxoma, yes or no? Non-mobile mass protruding from the interatrial septum that partially occludes. This is over here. Okay. Okay, look. Okay, my apologies. Even I thought this was a myxoma. I didn't really read it properly. The patient has a history of a melanoma. This is a metastasis. My apologies. This is not a myxoma. This is a patient who had a history of melanoma, now has metastasized to the heart. Okay, so can we use this question to remember that melanomas can have metastasis to the heart? Yes or no? Okay, let's move forward to the next question. Which of the following is the most appropriate dietary recommendation for this patient? The correct answer for this one is there's no changes. Oh, okay, because this patient is a 22-year-old man who has essential fructosuria, so no changes. If the patient had problem with proper fructose metabolism, for example, over here in the biochemical pathway, if the patient didn't have aldose reductase, aldolase B, not aldose reductase, aldolase B, would the patient have jaundice? Yes or no? In primary fructokinase deficiency? Yes. Okay, so since this patient has absolutely no problem, he just has a little bit of reducing sugar in his urine. As a result, no changes are needed for this patient. Have I made myself clear? Okay, next one. Which of the following enzymes contribute to maintaining a normal serum glucose level in this patient? Correct answer for this one is A. Did we talk about this question before? Okay, let's move forward. Further evaluation will most likely show which of the following. Very good. This is pulmonic valve stenosis because of carcinoid syndrome. Okay, are we clear? Yes or no? Abdominal cramp, watery diarrhea, episodes of heart palpitation. This patient is a patient of carcinoid syndrome. And do you remember I told you when I talked about carcinoid syndrome, does carcinoid syndrome affect the right lung or the left lung? The answer is it affects the right lung. Why? Because the left lung has monoamine oxidase. Yes, monoamine oxidase breaks down the serotonin. That's why the left part of the heart is not affected. My apologies. So right heart is affected, left heart is not affected. Okay. Are we clear? Yes or no? A common clinical maneuver to diagnose the patient's symptoms involves stimulation of which of the following nerves? Which one did you guys choose? Very good. Which one did you guys choose over here? The sound is loudest. Which of the following is the most likely cause of this finding? Very good. Which of the following is the most likely underlying cause of the patient's cardiac disease? Type 2 hypersensitivity. Very good. Okay. This patient has anisco cells. Yes. Rheumatic fever. This is rheumatic fever. Fever, shortness of breath, diastolic murmur. This is a type. Do you remember we talked about how rheumatic fever is a type 2 hypersensitivity disease? Yes or no? Okay. Over here, you can see lymphocytes and formation of a little bit of fibrotic tissues and inflammatory cells. This shows anisco cells. Okay. And Ashok bodies. Let's move forward. Which one did you guys choose over here? Which of the following is the underlying cause of the patient's condition? Which one did you guys choose? Very good. Fibrovascular dysplasia is the correct answer for this. Okay, let's move forward. Which one did you guys choose over here? Very good. Hypotension. Okay, this is a potential side effect of PDE inhibitor. Okay, are we clear, everyone? Yes or no? They inhibit an enzyme that is responsible for the degradation for CAMP. As a result, what would happen? Increased CAMP would result in vasodilatation, and vasodilatation will cause hypotension. Okay. Which of the following is the most likely explanation for this finding? Which one did you guys choose? Okay. Everyone chose D. The correct answer for this one is C. Why? Because over here, the patient was treated with lisinopril. Results of the testing shows decreased contraction, concentrations of arginine. Which of the following is the most likely explanation for this finding? The most likely explanation for this finding is, why is there decreased arginine? There's decreased arginine because all the arginine is converted to nitric oxide. Yes or no? Do you guys remember that we get nitric oxide from arginine? Yes, it's all consumed. Very good. So C is the correct answer. Which one did you guys choose over here? Okay. A pulsatile mass in the periumbilical region is for abdominal aortic aneurysm. For aortic aneurysm, what is the number one cause of aortic aneurysm? Blood vessel weakness due to atherosclerosis. So that's why foam cells accumulation is high yield. Next one over here. Which of the following additional finding is most likely in this patient? Which one did you guys choose? Okay, this is E. Very good. Okay, further evaluation is most likely to show which of the following laboratory changes. Which one did you guys choose? Very good. Congratulations, patient in adrenal crisis. Very good. Which one did you guys choose over here? Which of the following is the most likely cause of the patient's findings? Which one did you guys choose? Very good. Congratulations. Okay, good choice. Let's move forward. That was a patient of aortic dissection. Which of the following is the most likely physiologic effect of this drug? Which one did you guys choose? Very good. Unfortunately, the correct answer is A. Okay, because over here, pharmacology with sotalol. Sotalol is, although it's a class 3 drug, it's also a type of beta blocker. So increased potassium efflux from myocytes over here. Sotalol will not cause potassium efflux. If it's a potassium channel blocker, it will not cause potassium efflux. It will keep the potassium. It will keep the potassium outside of the cell. Are we clear? Yes or no? Okay. What type of a channel causes potassium efflux? That's a sodium potassium ATPase channel. Okay. Let's move forward. Which one did you guys choose over here? Biopsy of the dorsalis pedis will show which artery finding. Very good. Segmental thrombosis. Okay. We haven't talked about this. This is Raynaud's phenomenon. We'll talk about this in the future. But if you chose B, then that's a correct answer. Okay, next, let's move forward. Which one did you guys choose over here? Which one did you guys choose? Very good. Okay, patient has cystic fibrosis. As a result, what happens? If someone has nasal polyps and dry skin, then that's an indication of cystic fibrosis, more or less, especially in a young girl. So do they also have decreased pancreatic enzyme release? The answer is yes. Can vitamin D be absorbed? The answer is no. Will calcium be low? The answer is yes. Okay, so A is the correct answer. Very good. Which one did you guys choose over here? This patient has pituitary adenoma, yes, and hyperparathyroidism. Is this MEN1 or MEN2? This is MEN1. In MEN1, there's a mutation in MEN1 tumor suppressor gene. Do you guys remember the name of that protein that's produced is menin? Yes or no? Menin, yes. Okay, good. So C is the correct answer. Okay, this one is a difficult one since we haven't discussed this. This is your sixth aortic arch. Sixth aortic arch is responsible for the ductus arteriosus. Okay, we'll talk about this in the future, but for now, keep in mind, sixth aortic arch is for ductus arteriosus, for PDA. Which of the following will likely show the following findings? Which one did you guys choose over here? Very good, congratulations. Which one did you guys choose over here? Very good, A is the correct answer. Okay, which one did you guys choose over here? Which of the following is the most likely pathogenesis of this patient's condition? Okay, this patient has delayed pulsatile release of gonadotropin. Okay, why? Because over here, this patient has constitutional growth delay. He doesn't have any other problem. Look, it's a 13-year-old healthy girl, birth weight was normal. His father says that he was an otherwise healthy girl, comes to the physician, her birth weight was normal. Her father says that he was a late bloomer. Okay, over here, do you see a problem with the question? Yes or no? Do you see a problem with the question? What is the problem with the question? Can anyone tell me the problem with this question? Okay. When you read this, her father says that he was a late bloomer. Who was the father talking about? Was the father talking about himself or the girl? Himself. Okay. So do not get confused. Do not think that the father is describing the child. A lot of students, that's where they make the mistakes. They think that the girl is actually has a karyotypical problem. Okay, so that's not what it is. When you see something like this, her father says that he was a late bloomer. Obviously, this means that the father is talking about himself. So this patient has absolutely no problem. He only has a constitutional growth delay because everything else is more or less okay. Estrogen is okay. Mildly decreased is normal. Okay, so that's that. Which one did you guys choose over here? Which of the following hormonal changes? Very good. Increase RT3. Which of the following is the most likely to improve this patient's symptoms? Which one did you choose? Very good. Administration of which of the following is the most appropriate next step? Which one did you choose? Very good. This patient has a beta blocker toxicity. Yes, prolonged PR. Okay. What are the 3 drugs that we give for beta blocker toxicity? Are the 3 drugs known as SAG? Yes, very good. SAG, saline, atropine, and glucagon. Okay. Which one did you guys choose over here? Very good. This is SIAD. Okay. Which one did you guys choose over here? Very good. B. Okay. Very good. Further evaluation is most likely to show which of the following findings. Which one did you guys choose over here? C. This is impotence. Okay. Because the patient has a prolactinoma. Do you guys remember that for prolactinoma in men, do you remember I told you that in women, the number 1 problem is galactorrhea. In men, the number 1 problem is impotence. Do you remember this? Since it's a man, that he will not have galactorrhea first, he will have infertility or impotence first. If it's a woman, she will have galactorrhea first and impotence later, or infertility later. Okay. Which of the following is the most appropriate pharmacotherapy? Which one did you guys choose? Fast answers, please. Which one did you choose? This is glucocorticoids, right? Because the patient has adrenal crisis. Are we clear? Addison's disease. Okay, which one did you guys choose over here? Very good. E. Okay, which one did you guys choose over here? Very good. Congratulations. Okay, good job. Recurrent abdominal pain, greasy stool, multiple round echogenic foci with prominent posterior acoustic shadow. This shows that there's a tumor of pancreatic delta cells. That's why. Okay, another thing is, if you do not want to make the diagnosis based on this, then you can simply see abdominal pain, greasy stools, and weight loss. Do you realize why will there be greasy stools? There will be greasy stools because there is decreased release of pancreatic enzymes. Which hormone is responsible for preventing the release of enzyme? That's somatostatin. Yes or no? So somatostatin is being secreted excessively. As a result, there's decreased release of all the secretions from the endocrine organs. Have I made myself clear? Yes or no? If it was glucagon, wouldn't the patient have necrotizing migratory erythema? Necrolytic migratory erythema, or some sort of a rash? Yes or no? Yes. Okay, let's move forward. The difference between atrial and ventricular rates is due to which of the following? Which one did you guys choose? Very good. Atrial fibrillation. Okay. Are we clear? Yes or no? Absence of P waves and RR intervals. Did we not do this before? Yes. Did we not do this before? Very good. The drug administered most likely has which of the following effects on cardiac pacemaker? Which one did you choose? Okay. What was the name of the drug? The name of the drug that she was given is what? Can anyone tell me? The drug is, first and foremost, what is the drug? The drug is catecholamine, yes, epinephrine, because the patient has an anaphylaxis. And epinephrine, what will epinephrine do? The drug administered will most likely have which of the following on cardiac pacemakers? So over here, epinephrines, they are going to stimulate the beta-1 receptors. And when they stimulate the beta-1 receptors, there is opening of the L-type calcium channels. And this increases the time for the calcium entry. As a result, there's increased depolarization. Have I made myself clear? Yes or no? If there's increased depolarization, then can there be increased force of contraction? Yes. Will there be increase of heart rate? Yes. As a result, will there be reversal of the anaphylaxis? The answer is yes. Okay. So have I made myself clear? Yes or no? Okay. First and foremost, in cardiac pacemaker cells, do we have phase 3 in cardiac pacemaker cells? Yes. We have phase 3 in the cardiac pacemaker cells, but if we have increased sodium entry in the cardiac pacemaker cells, will this cause increase of heart rate? The answer is yes. But will this cause increase of force of contraction? The answer is no. Okay. Have I made myself clear? Which one did you guys choose over here? Which of the following is the most likely causal organism? Which one did you choose? Very good. B. The correct answer for this one is B. This is Enterococcus fecalis. Can anyone tell me why? Okay, since it's an old man, transurethral prosthetic resection for BPH. Over here, they're describing the organism as non-hemolytic, and the patient is PYR positive, folks. So that describes an enterococcus. Okay, which one did you guys choose over here? Very good, progesterone. Last question, which one did you guys choose? Very good, increase in vagal tone. Inhibition of myocardial sodium potassium ATPase? Not really. The answer for this one is increase in vagal tone. Why? Because this is also a correct answer. The primary action will work like this. However, digoxin usually also works in the AV node. In the AV node, digoxin increases the vagal tone. If you guys see your first aid, in the first aid, you will see that they have mentioned two types of things. First and foremost, digoxin is known to increase contractility and decrease the increase the rate slowing activity of the AV node. So it has two actions. Number one, increase contractility and increase in vagal tone. Over here, since they are saying that ECG shows prolongation of PR interval, this means that this patient has increased vagal activity, right? Parasympathetic activity. So that's why vagal tone is increased. For example, today we talked about beta blockers. Does beta blocker increase your PR interval? Yes or no? The answer is yes. Okay, so just as how beta blockers increase PR interval, digoxin also has the ability of increasing the PR interval and increasing vagal tone. As a result, giving the heart enough time to fill up with blood so that it can contract more efficiently. Have I made myself clear? Yes. 37. Number 37 is over here. This patient has anaphylaxis. If someone has anaphylaxis, we give epinephrine. The point of giving epinephrine is to increase the force of contractility and to increase the heart rate. So over here, if you increase calcium influx in phase 4, in the phase 4 of calcium influx, if calcium entry increases, not only do you have increase of the rate of depolarization, you also have increase of force of contraction. So epinephrine will have no effect on the sodium level, only affect the calcium level. Have I made myself clear, yes or no? Because by increasing calcium level, you're increasing the heart rate and the force of contraction at the same time. Are we clear, guys? Okay. Okay. Does anyone need any more explanation? Okay, good. Let me tell you something. If you need more explanation, you guys will get the recordings. In the recording, you guys will have different phases where you will see the explanation over here. So please pause the video on your recording and read the explanations if needed. Okay. Are we clear? Yes. Okay. Yes. Are we clear about number 37, Dr. Ithar? Epinephrine, what does it have to do with the calcium channel? Is that what you're saying? Oh, not really. Okay. So first and foremost, let me talk about this one more time. Let's read the question very quickly. The drug administered will most likely have which of the effect on cardiac pacemaker cells? So in this case of anaphylaxis, we are giving the patient epinephrine. Epinephrine, the way that it works is that it increases the influx of calcium, right? And as you can see over here, okay, and as you can see over here in this phase, what is this phase called? This phase from here to here, what is this phase called? Phase 0, 4, or 3, which one? Phase 0. Which one is this phase called? phase 4. So what happens is the epinephrines, what happens is over here at phase 4, they start opening the calcium channel. Have I made myself clear? Instead of letting the calcium channels open at phase 0, they open the calcium channels at phase 4. If that's the case, then isn't there an earlier chance of having a depolarization? Yes or no? Have I made myself clear? Yes. Okay, now are we clear, Dr. Ithar? Congratulations. Okay, good. Now let's talk about the answers. Okay, you're absolutely welcome. Anytime, ask me questions. Okay, now let's talk about the results. The passing mark for this exam is 22 out of 40. Anyone who scored 22 out of 40? Congratulations. Okay, so who are the physicians who scored 22 out of 40 or more? 22 or more? 26, congratulations, Dr. Ellen. Okay, Dr. Ellen, congratulations. Who else? Dr. One second. Nazaret, 29. Dr. Zareen Tasneem, 25. Dr. S, 28. Who else? Dr. Ithar, 28. Who else? Who else has scored highs? Anyone else? Okay. So to all the physicians who have scored high, congratulations, Dr. Nazaret, for scoring a really good mark. Congratulations to Dr. Ithar, Dr. S, for scoring a really good mark. Congratulations to Dr. Zareen Tasneem and Dr. Ellen for scoring a really good mark. Really proud of you guys. This exam was a very difficult exam. Okay, and to score this sort of mark in the exam shows, let's see, if you guys sit for the Usmle and if you get a cardiovascular question, what are the chances that you will get the cardiovascular question right? Okay, so basically, let's consider Dr. Tasneem's score. Okay, so there's a 65% chance that Dr. Zareen Tasneem, you'll score a very good mark in your CVS. The same goes for Dr. Nazaret, for example. There's a 72% you'll score a very good high mark for Dr. Ithar and Dr. S. Okay, 70%, that's very good. Dr. Ellen, 62%, very good. Anything above 60% is a pass. Have I made myself clear? Yes or no? So congratulations, I'm really proud of you guys. You guys did absolutely amazing. Now, what plans do you guys have for your Christmas? Do you guys have plans for your Christmas? Study? Okay, I would advise you guys to take a break, have some fun with your friends and family, right? And then we will start our class again on Monday. So with that being said, thank you so much. I really appreciate your time and effort. Really proud of you guys. Keep up the good work. And I wish you guys a very, very happy Christmas. And if you guys have any questions, please send us an email. We'll get back to you. And yes, next will be reproductive. No, next will be renal system. Next will be renal system, not reproductive. Okay. After renal, then we will do reproductive system. Okay, so and to all the students who are listening to the recordings, Merry Christmas to every one of you. Hope you guys have a great day. I'll see you guys on Monday. Okay, so thank you so much. Bye-bye.